Hepatitis A. Etiology and pathology. Hepatitis A is an acute hepatitis caused by an RNA virus that is spread by the fecal-oral route. Figure 58 shows the histological picture of acute viral hepatitis. Epidemiology. Hepatitis A is the commonest cause of viral hepatitis in the UK, with an incidence of symptomatic disease of about 6 per 100,000, most commonly between the ages of 20 and 45 years. Asymptomatic disease is common in childhood. 5% of children in the UK are immune by 5 years of age, compared with 74% of people over the age of 50 years. Better sanitation means age of first exposure is increasing. Most cases are sporadic. Hepatitis A endemic regions include, but are not limited to, Mexico, parts of the Caribbean, South America, Central America, Africa, Asia, except Japan, the Mediterranean basin, Eastern Europe, and the Middle East. Hepatitis A remains the most common vaccine-preventable disease in travelers to endemic regions, who can contract hepatitis A by ingestion of contaminated drinking water or ice, uncooked fruits or vegetables grown with or washed in contaminated water, or raw or uncooked shellfish, oysters, clams or mussels. Outbreaks can be seen in daycare centers where children have not been toilet trained, after breakdowns in usual sanitary conditions such as natural disasters, and occasionally through blood transfusions or by sharing contaminated needles and syringes. The incubation period is 15 to 45 days. Clinical presentation. Common. Most cases are asymptomatic, with symptoms and severe disease more common with increasing age. If symptomatic, the presentation is of an acute hepatitis with nonspecific symptoms of lethargy, arthralgia, anorexia, nausea, and mild upper quadrant discomfort, prodrome, followed by jaundice. The latter is associated with pale stools and dark urine. Itching can occur in the cholestatic phase of illness. Physical signs. Features of an acute hepatitis, tender mild hepatomegaly, jaundice, are common. Splenomegaly is seen in 15% of cases. Investigation. Liver biochemistry. High serum transaminases, peak usually greater than 1000 U/L, with or without raised serum bilirubin, alkaline phosphatase raised in cholestatic phase, normal albumin. Serology. The presence of hepatitis A IgM indicates a recent infection, Fig 59. Differential diagnosis. See Table 44. NB. In those with atypical hepatitis who are seronegative for hepatitis A and B, be sure to specifically request hepatitis E testing. Treatment. This is supportive, with intravenous fluids if vomiting. Rare cases of acute liver failure need special management. Complications. NB. A cholestatic phase in acute hepatitis is common, can last between 12 and 18 weeks, and is associated with rising bilirubin, i.e. 400 to 500 mol/L, and alkaline phosphatase and falling serum transaminases. Relapsing disease is rare, occurring in 6%, but there is no chronic state. Prognosis. Hepatitis A is self-limiting with no residual liver damage. Symptoms and signs usually resolve within 3 weeks. Acute liver failure occurs in 0.14 to 0.35%. Death occurs in 0.04% of patients with symptomatic disease. Prevention. Passive immunization. Pooled serum immunoglobulin can be given to close contacts of a case of hepatitis A within 2 weeks of exposure. Active immunization. Formalin inactivated vaccine is indicated for travelers to high-risk areas, homosexuals, intravenous drug users and those with chronic liver disease. It provides protection for 5 to 10 years.